All right, good morning, everybody. Welcome again to Grand Rounds. We're excited to have you all here because we have a great turnout today. We are excited to have Dr. James Krings here today with us. Dr. Krings obtained his medical degree from Stanford University, and then afterwards he went to Northwestern University in Chicago for residency before returning here to his hometown of St. Louis and joined us as a pulmonary critical care fellow, completing his fellowship here. As a fellow, he thought that working in the ICU was not enough. He decided to complete a Master of Science in Clinical Investigation, a mentor training program in clinical investigation, and a mentor training program in implementation science, all focused on the management of asthma. He then joined faculty here, and as faculty here, he's continued his work on the care and management of patients with asthma and COPD, including studying the use of advanced quantitative imaging in these diseases to better understand, various variations in responsiveness to current therapies. He's received several awards and grants for this work, including the American Lung Association Early Career Investigator Award and the Outstanding Citizenship Award from the Clinical Research Training Center here at WashU. In addition to all of this, he puts his work into direct practice here in St. Louis. He partners with local clinics to improve the use of guideline-recommended asthma care and to help better treat our patients with asthma in the community. In line with all of this, Dr. Krings has prepared what I'm sure will be a fascinating talk on the management of asthma and smart therapy today. So without further ado, please help me welcome Dr. Krings.
Well, thanks for having me. Thanks for the intro, and thanks for everybody's time to listen to this talk. We'll be talking about smart therapy in asthma and how I think the best way to take care of people with asthma is in the year 2024, and thinking about things pragmatically for people with asthma. I'll throw up my obligatory disclosure slides and highlight a few things. We are lucky to be funded by the NIH as well as the ALA, who's been very supportive of us. We have an upcoming PCORI study that's related to some of this work that we're doing. And I have been working with the CRTC and the ICTS for 10 plus years now, and have gone through pretty well every training program they have. We do some industry-sponsored studies. I will highlight one. We do work with AstraZeneca, who is the maker of one of the inhalers that we'll be talking about, and budesonide formoterol. So an outline of what we're going to be talking about today. Number one, we'll talk about the background on asthma and really focus on where we're at in the year 2024. We'll talk about the latest evidence-based asthma therapies, and we'll try to tie in some D&I science. We'll talk about what we're doing with the federally qualified community health centers in St. Louis. And this is meant to be very pragmatic, so I would love for people to interrupt me, and I hope that you leave here feeling more comfortable taking care of people with asthma. So I want to stop for just 1 second and ask for 2 quick hand raises. So who in this room feels comfortable with what smart therapy is in asthma? Plus or minus has maybe prescribed smart therapy for asthma. If you could raise your hand. Okay, so maybe about half and half. And who's comfortable with what D&I research is? Okay, less. So maybe about 20% or something like that. So I recently had twins. I had identical twin girls. And right now, my mom came over this morning because my wife and I both had to be out of the house around 7 a.m. And I'm realizing that raising a family takes a lot of people, right? So I would say doing this work as well takes a lot of people. And we had to recognize those people right up front. I have a wonderful group of people that I work with in our lab. I have wonderful mentors, many who are right here. We have a great group of trainees, including pulmonary critical care fellows, students at the Brown School, internal medicine residents. And one of the fun things about D&I is that you get to collaborate with people that are completely outside of medicine. So we work with people in economics, and we work with people in the healthcare design studio. I'll highlight all of their work at different points. And then finally, And perhaps most importantly, I want to recognize our community partners who have, at least so far, trusted us to come into their busy practices. So let's start with the background. So I like to paint this as like a state of the union. Where are we at? What's the state of the asthma union in St. Louis in the year 2024? And what I argue to you is 4 things. Number 1, asthma is extremely common. And we have so many exciting new asthma medicines that we prescribe all the time in our severe asthma clinic. Yet, if we look at the outcomes for asthma, they are not improving for most people. Next, I'm going to argue to you that asthma outcomes are marked by vast inequities, and our hometown of St. Louis epitomizes every one of those things. So asthma is common. 450,000 people die of asthma in the world every single year. 96% of those are in developing countries. Look to the right. Now we'll look at it from a US perspective. 25 million Americans have asthma. 1 in 10 kids have asthma. It costs our country $80 billion. Somewhere between 3,000 and 4,000 people a year die of asthma. It is the #1 reason that kids miss school because of a chronic illness. Causes 14 million missed workdays. 3 in 5 people tell us they limit their physical activity because of asthma. 71% of people misuse their inhalers. Gave this talk yesterday at the VA, and I had to throw this photo in the lower left from House. Somebody was bringing up how they keep observing people not using their inhalers correctly. And if you remember from this episode, House asked this woman, "How do you use your inhaler?" And the woman says, "Oh, I use it correctly," and then sprays it on her neck like cologne. So 1 in 5 people cannot afford their inhalers. And mortality from asthma is not declining. And I'm not trying to be overly dramatic here, but look on the left. You look at the cancer death rate in the United States since the year 2000, and you'll notice that for males and females, that rate is declining over time. That's great. You look on the right, this is the asthma mortality rate over that exact same time period of the last 20 years. And like I said, I'm not trying to be overly dramatic. The y-axis is totally different here. The scales are totally different. But my point is that we have a lot of new asthma therapies, and asthma mortality is just ticking along. It's not getting any better. On any given day, 11 people are going to die of asthma. You know, maybe that's a lot, maybe that's not a lot, but I would argue to you every one of those 11 deaths is very preventable. So many asthma patients that die of asthma do not use their maintenance inhaler. This comes up for me a lot in the ICU, where we'll see somebody that's intubated for asthma, and somebody will say to me, "Oh, but they had mild asthma. They were only taking albuterol before." I say, "Well, that sounds right. They were just using albuterol before." So ICS use is associated with decreased asthma mortality. This is a study on the left from the year 2000. It was a prospective cohort analysis in Canada, and what they found after following people for 16 years is that for every canister of an ICS that somebody refills in a year, their risk of dying for asthma decreases by 21%. You contrast that with what's on the right. This is a study from 1992, also in Canada, where they followed 12,301 people, and they found that for every albuterol canister, extra albuterol canister somebody refills in a month, their risk of dying goes up by 90%. So you just got a flag in your head. When you see somebody that's not using inhaled corticosteroids and they're recurrently refilling albuterol, that is your high-risk person right there. Asthma is marked by humongous inequities both globally and in this country. This is data from the CDC from the year 2020, and people that identify as Black or African American are around 3 times more likely to die from their asthma. And I argue to you that St. Louis epitomizes health inequities in asthma. St. Louis has been named an asthma capital. People in St. Louis, or children in St. Louis, suffer from asthma at a rate that's 3 times higher than the rest of the country. In the St. Louis metropolitan area, despite representing around 20% of our population, people that identify as Black or African American represent 57% of our hospital stays for asthma. This has been well written about in the media. This was an article in the upper right from The Atlantic in 2010 that's talking about the makings of an asthma epidemic in St. Louis. More recently, this is work from Kelly Harris in the year 2019 that was picked up by St. Louis Public Radio, talking about how asthma rates are highest in North St. Louis. So for an upcoming, or for a recent grant, we put together this figure 1. And we created these maps that looked at, by zip code, where is our asthma morbidity located. And if you look at the kind of lower left map right here in blue, this is where the zip code that people are coming from when they're hospitalized for asthma. And if you kind of look at the other maps right next to it, that's where people identify as Black or African American, or where people are living below the federal poverty line. And I think it's very striking that all 3 of those maps will look very similar. We put together a bar graph that broke people up by race and ethnicity on the top, and people that identify as Black or African American are around 8 times more likely to be hospitalized for their asthma as compared to their counterparts. I will point out that this corresponds very closely with what's been well written about with the Delmar divide, and this is a humongous healthcare inequity we need to be working on. So I hope I've convinced you so far that we need to do better. We need to do better on asthma in the country, and we need to do better on asthma in St. Louis. So what can we do better? Well, I'll argue to you a few things. Number 1, I think asthma care is way too confusing. Inhalers are way too expensive, and people aren't taking the right inhalers. People are not taking their inhaled corticosteroids and are really relying on albuterol. In the lower left, I pulled this 2 days ago. This is the cost of an inhaler that we'll be talking about, budesonide formoterol with a coupon, is somewhere between $200 and $300. There is an over-the-counter inhaler that is out there that many of our people are taking. It is inhaled epinephrine on the right side. I pulled this from Walmart.com. I have presented this slide multiple times, and I always try to pull the new data on how often this inhaler is being prescribed. And every time I've pulled it, it is a bestseller. It's a popular pick. 500 people had bought it since yesterday on Walmart.com, and it's in 200 people's carts right now. So the next thing I'd ask is, who knows how to use all of these? And I can tell you with 100% confidence the pulmonary fellows do not know how to use all of these. And it is darn confusing, and there keeps becoming more and more. And you may prescribe one, and maybe you're really good in your clinic, and you walk people through how to use it, you take your time, you point them to videos, and then they get home, and they find out that that's not on their formulary, and darn, they got to get a different one. But the problem is it's not a pill, it's a totally different device, and they need to learn how to use that. Is that realistic? And then I pulled up 4 inhalers on the left. Every one of those inhalers is different. Some of those are reliever inhalers, some of those are maintenance inhalers, some of them can be used as either. And I'll tell you what, I think all 4 of those inhalers look really similar. So I think it's time to think simply and practically about asthma and think about the patients. What is the best way that we can help them? So this is a point where I'm going to try to make this a little bit interactive, and I'm going to ask people to get out their cell phones. I get very nervous that this won't work, but we'll try. So the easiest way is to do the QR code. If for some reason your camera doesn't work, there are alternatives. We claimed the Pull Everywhere asthma account. We're very happy with that, so you can always text asthma to 22333 as well. So, sort of look like it's working, maybe? Okay. So I'm going to give you a real-world case, and then I'll open it up. And I think this is a very practical case that anybody that takes care of people with asthma may run into. So this is Sophie right here on the right. Sophie is a 28-year-old female with asthma. She has symptoms of wheezing when exposed to cold air. This happens 2 to 3 times per week. Never wakes up with these symptoms at night. Has exacerbated once for her asthma, requiring prednisone. This was 15 months ago. And you talked with her and says, God, I always forget to take my inhalers because they're kind of expensive. And I forget them anyways. If I'm feeling well, I just kind of forget them. Her FEV1 is 82% of predicted, has a positive bronchodilator response, meaning you're confident about her diagnosis of asthma. And you look at her healthcare payer and you notice that it's Missouri HealthNet or Medicaid. And I ask you, what treatment will you prescribe for her? And think in your head, why am I prescribing that treatment? So I'm going to try to open this up now. We'll see if this works. Yeah? Yeah? Wow, I'm surprised. Okay. All right, we'll see if the next thing works now. Look at people's responses. Okay, so some people in the room are going to prescribe albuterol. Answer B being the one that is the most commonly answered, fairly, is not surprising. I'd say most of the time I present this, answer B is the most commonly prescribed answer, and I would say is the classic answer, what I learned when I was in medical school and residency as well as the correct answer. And then there's some people that are trying to get into this kind of new paradigm of treating people, of treating this person with reliever budesonide formoterol, particularly identifying her as a forgetful person. But people are a bit confused on what dose to prescribe. Is it C or D? And we'll talk through the dosing on that. I will argue to you that the correct answer is D. And this is about right about how often people answer D, maybe about a third of the time. Okay, so we are talking for this part about mild asthma. So first thing is, what is mild asthma? Things can get complex. I think we make things overly complex in medicine. There's so many different criteria that can make you fall under mild, moderate, or severe. But let's just keep it basic. What mild asthma is asthma that doesn't have daily symptoms. If your asthma is not affecting you every single day, you probably have mild asthma. Mild asthma is most people with asthma, somewhere between 50 and 75%. And I think I already drove this point home. People that are billed with having mild asthma can still have life-threatening asthma. And in fact, a third of people that die of asthma have been billed as having mild asthma. If you look at our guidelines, we no longer use the word intermittent, and they even argue that using the word mild may be counterproductive. And I try to be very mindful of this in my clinic. I don't tell people you only have mild asthma. I'm not trying to make them feel better. Don't worry, you only have mild asthma. Because what are you telling people? It's no big deal. What you're telling them is don't worry about it. Just go about. Are they going to go home and adhere to their inhalers and come back and see you if you just go, oh, you have mild asthma? I say you have asthma that is serious, and we can help, and we ought to, with the right treatments, we ought to be able to keep you out of the hospital for the long term. Maintenance inhaler adherence is really bad in this group because people don't take it seriously. And there's something called the SABA paradox, or you could call it the albuterol paradox, and we'll talk about what that is. And I'll argue to you that there's a simpler way to treat people with this group of asthma than what we've been doing historically. So this is our recommendations for the treatment of mild asthma. Mild asthma is step 1 and step 2 asthma. This is from the Global Initiative for Asthma. And if you look at what's preferred at step 1 and step 2, it is reliever low-dose ICS formoterol. And this person, that case I pulled up for you, I would argue is in step 2, and they would say an alternative but not a preferred treatment is that maintenance low-dose ICS and reliever SABA that most people answered. So why the new guidelines? Well, let's just take a step back and think about asthma. So we know that SABAs like albuterol do not treat airway inflammation. And there's something interesting. Even short-term regular use of medicines like albuterol without an inhaled corticosteroid can result in people's airways becoming more inflamed and their airways becoming more hyper-responsive. So look at the figure on the lower left. And this is looking at airway reactivity. So this is their PD20 on a methacholine. So you give somebody a medicine like methacholine, and you look to see what dose of methacholine is required for their FEV1 to drop by 20%. So the quick way to think about that is a lower number means their airways are more hyperresponsive. It took a more dilute amount of methacholine for their FEV1 to drop by 20%. This was a randomized crossover study of 34 participants, and they had people repeatedly either take placebo, short-acting beta agonists like albuterol, an inhaled corticosteroid, or both an inhaled corticosteroid and albuterol. And then they looked at their methacholine, their PD20. And so what you'll notice is that people that are taking placebo or albuterol repeatedly have a very similar methacholine. Their airways are about the same amount of reactivity. And in fact, maybe the SABA group is a little bit worse. Now, you contrast that with people that are taking inhaled corticosteroids, and you'll see that their airways are less hyperresponsive. Next, look at the figure on the right. This is airway inflammation. And this is, they assess this by what people's eosinophil counts were in their sputum. Same kind of 4 groups. Higher value here is going to mean that their airways are more inflamed. So maybe this is a little bit more convincing to you. If you compare the placebo group to the SABA group, and this was statistically significant, their airways become more inflamed when they repeatedly take a beta agonist like albuterol without an inhaled corticosteroid. And you contrast that with the far right, people that are taking inhaled corticosteroids, their airways are going to become less inflamed. So let's apply this to Sophie, who comes in and tells you, and this will drive home, I think, the SABA paradox. Sophie tells you, yeah, I have asthma, but I forget to take my maintenance inhaler. It's expensive, I forget to take it. So this is her, I would argue, on the top. And this is a figure we created for one of our articles recently. The black line here as we go along is her asthma symptoms. The yellow dotted line is her airway inflammation. If you see a blue mark, that means remember to take a short-acting beta agonist like albuterol. A red vertical line is her remembering to take her maintenance inhaler, her maintenance ICS inhaler, because you prescribed her the classic paradigm. So it was ticking along, not having a whole lot of asthma symptoms, so I'm not going to take any inhaler. Why would I? I'm feeling good. And then who knows what happens? Maybe it's the spring and this pollen count kicks up, or her 1-year-old gave her virus number 2 million. But it's going through. Her symptoms are kicking up and her airways are becoming more inflamed. So what do? Well, I'm feeling worse. I'm going to go grab my albuterol. Right? And so I'm taking my albuterol, and that's all these blue lines. Maybe once in a while I'm like, oh yeah, I have another inhaler that's in a maintenance ICS. There's that red line in there. And I told you that repeated doses of a beta agonist do nothing to make your airways less reactive, and in fact may make your airways more inflamed. So there's this kind of cascading thing that's happening. Her is taking more and more and more albuterol. Her airways are becoming more and more inflamed, more and more hyper-responsive. Darn, things are kicking out of control. All of a sudden, there is in your ER. And I hope this isn't one of the bad ones, right? This isn't one of the ones that results in her getting admitted to the hospital. So there's this red mark right here. You treat her with a course of prednisone, and then her airways become less inflamed, her asthma symptoms get better, and then kind of just keeps trucking along, not taking her maintenance inhaler until the next time this happens. What if you did something different? What if you combined her beta agonist with an inhaled corticosteroid? So every time you're going to take that beta agonist to make you feel better, you're also going to be taking an inhaled corticosteroid. So that's at the bottom here, right? So this is trucking along. The exact same virus comes along, but you never prescribed her an albuterol inhaler. And so now is grabbing her budesonide formoterol inhaler, and that's all of these green marks here. And that budesonide formoterol inhaler obviously has an inhaled corticosteroid in it. It's treating her airway inflammation at the exact same time, and as her symptoms go up and up and up, is taking more and more and more inhaled corticosteroids and is self-titrating herself. And lo and behold, her airway inflammation is able to be calmed down and averts the entire ER stay. So that sounds great, right? That sounds great in theory. Let's see what happens in real life. Well, this has been tested now, right? So this was 4 landmark studies that we've had, 3 of them in the New England Journal of Medicine, 1 of them in Lancet, the Sigma 1, Sigma 2 novel start and practical trial that looked at this very thing. What if we prescribe people with mild asthma as-needed budesonide formoterol versus these kind of other more classic treatment paradigms for mild asthma? And the bottom line is that when you compare as-needed budesonide formoterol versus as-needed albuterol, somebody's risk of exacerbating goes down by about 2/3. You look at that on the right. If you compare as-needed budesonide formoterol to maintenance ICS and as-needed albuterol, their risk of going to the hospital or ER visit goes down by 1/3. And on top of that, you, as compared to the maintenance ICS plus as-needed albuterol group, you are exposing them to less inhaled corticosteroids. So let's go through a second real-world case. This is Mac right here on the right. So Mac is a 19-year-old male with asthma. You are seeing him for a loss of asthma control. He is taken care of on fluticasone salmeterol. I try not to use brand names because this is a CME, but this would be Advair or Wixela. This is the low dose, the 100 dose. Mac is good. Mac is adherent. He's taking 1 puff BID. You look through his EPIC refills, his PDC, his percent of days covered by Advair is 90%. However, even with good adherence, he has exacerbated 3 times in the last year, requiring prednisone. His FEV1 is 68%. He has a positive bronchodilator response. You similarly look at his healthcare payer and notice that it's Missouri Health Net or Medicaid. And I ask you, what treatment will you prescribe and why? So let's see here. All right, we'll see. All right, well, this is a little bit different. I think people are starting to get the sense of the talk. So they're going with C, and this is a flip over to smart therapy, and warms my heart. People are getting the right answer. I will say, having given this talk multiple times, people will often answer A, and again, that's what I learned in medical training. That you would step people up. This is step up. You're uncontrolled, you step up their ICS dose. You go from the low dose fluticasone salmeterol to the moderate dose. B and C are both some variants of smart therapy, with C being the correct variant. And D always makes me laugh because it depends on where I give this talk. Sometimes you give this to like a group of specialists that are like throwing up D, and you're like, whoa, spent a lot of money there. Let's slow down a little bit. But I agree with you that C is the correct answer. So let's talk through C with why we think that's the correct answer. All right, now what did I do? Hopefully I didn't break it. Maybe I didn't. Let's see. No, I didn't. Okay, good. Okay, so we are now talking about step 3 and 4 therapy for this guy, for Mac. And our guidelines are pretty clear. We have 2 guideline bodies that we kind of follow in the United States, GINA and the NAPP. They both recommend smart therapy, single maintenance and reliever therapy for this. So what is smart therapy? Well, I'd argue to you it's a simpler way to use your inhaler because you only have to remember 1 inhaler. And on the right, instead of having 2 different inhalers, your fluticasone salmeterol and your albuterol, you just have 1 inhaler, single maintenance and reliever therapy that will look like what's on the bottom. There's no SABA paradox because every time you're taking your SABA, you're taking your inhaled corticosteroid. There's better efficacy. SMART has been studied in 22,000 people over the last 20 years, and we consistently know that it reduces somebody's risk of exacerbating by between 30 and 40%, and it's also patient preferred. People like it better. People like the simplicity of one inhaler. So let's put a little data behind why we think flipping to SMART would be the correct answer for MAC. So this is a meta-analysis from JAMA in 2018. And they looked at people that were uncontrolled with asthma. And they looked at either stepping up their ICS dose, so going from that 100 to 250, versus flipping them over to SMART. And flipping them over to SMART decreases their risk of exacerbating by 32%. I think we sometimes get lost in statistics. So let's think about this for MAC. What's the difference for MAC? Well, this is a figure that we put together with our partners in the Healthcare Design Studio. And if you believe the numbers I just pulled up for you, I would say that if we just stepped MAC up, his risk of having an asthma exacerbation in the next year is around 23%. So 23 out of 100 MACs will exacerbate in the next year. But if we, instead of stepping him up, took the time and flipped him to SMART therapy, 15 out of 100 MACs would have exacerbated in the next year. And that's an absolute risk reduction of 8% or 32% relative risk reduction. All sounds good, yet SMART is underprescribed. We interviewed clinicians. 70% reported they rarely or never prescribe SMART therapy. This was another survey when they found that 80 to 95% of clinicians are still prescribing SABA reliever therapy regularly in asthma. So I think this is a perfect example of an implementation gap. So we know what we ought to do. We know we ought to prescribe SMART, at least if we're practicing evidence-based guideline-directed medicine, and then we have what we do, and those are different. So this is normally the point where people stop me and they go, well, that sounds great, but let's be real. Everything in medicine is about money, right? Budesonide formoterol is expensive. Albuterol is not that expensive. So I can't prescribe people guideline-recommended care. And I stop them and I go, well, that's just not true, right? So we have had a wonderful partner in our work in Mo HealthNet or Medicaid, and they recognize what a humongous deal asthma is for Missouri Medicaid. If you look at the medicines that are most dispensed in Missouri Medicaid, the things that are up there are your statins and your inhalers. So yeah, they did some work for us in 2023, and they found that less than 5% of people covered by Missouri Mo HealthNet are prescribed SMART therapy. And yet they will cover up to 3 budesonide formoterol inhalers at either $0 or a couple dollars. So people are not prescribing SMART therapy, and it's not all about cost. So our team's beliefs that is guiding our work over the coming years is that SMART is guideline recommended and evidence-based, yet it's markedly underprescribed. And right here in Missouri, we have a wonderful opportunity to partner with people and get them to prescribe guideline recommended SMART therapy. And that ultimately, if more people are prescribing SMART therapy, particularly in communities where improvement is desperately needed, then asthma outcomes are going to improve. So, sounds good. How are we going to do that? That's when we turn to implementation science. So, implementation science is a relatively new field over the last 20 years, and it addresses that we know what to do, but then we don't do it. And of course, like everything, it has a definition. This is how it's defined: the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practices. It includes the study of influences on professional and organizational behavior. And as Dr. Powderly pointed out to me the other day, it is the fastest growing area of funding for the NIH. So we argued in a couple recent articles that SMART therapy is a perfect thing that needs implementation science. And in one of these articles, we created this figure on the right. So this is looking at what happens with the adoption of any new evidence-based practice. Smart therapy could be an example. There's the early adopters. There's the people who are like reading about asthma all the time. They're prescribing smart therapy, but that's not most people. And then you come to talks like this, and you talk to your friends, and you learn about it in med school and whatever, and all of a sudden smart therapy is becoming more popular. It's diffusing. And then you fast forward 10 years, and you're going to be practicing next to somebody who's prescribing therapy for asthma, and they're like, I'm not prescribing smart therapy. And you're like, oh my God, how are you not prescribing smart therapy? That's your late adopter over there, right? So implementation science is about moving that curve over to the left, accelerating things for people. And our argument is, if you're a math kind of person, that difference right there, that area between those two lines is your net benefit, right? Those are the people you're helping. So really awesome to be here. WashU is an implementation science powerhouse, and we have some of those people in this room right now. There are a lot of people in the Department of Medicine, across the Department of Medicine, that are doing D&I science in different areas. There are wonderful partners at the Brown School. There are every 6-week meetings called Wonder, where people sit around and talk about this kinds of stuff. So the next thing is, do we really need this? Do we need to make it this complex? And I argue to you, yes, we do, because what we've been doing does not work, right? Evidence-based practices are not getting adopted quick enough. So this slide I stole from Byron Powell. Byron's at the Brown School and perhaps one of the smartest people I know. And I think it's kind of a funny slide, right? This is what we do classically to influence behavior. Maybe we'll train people, and we stand on high and we go, oh, they're going to go do it now because we trained them, right? Maybe. Or you'll say, well, we've always done it this way. We've always prescribed asthma therapy this way, so that's just the way it ought to be. Or sometimes we'll just throw all of this stuff at people. We'll throw different aids, and we're going to train people. We're going to do 10 different things. And then since we didn't systematically study this, we don't know what works. What do we continue? I don't know. Or we do this one-size-fits-all, right? We do this a lot. So maybe I want to have a new protocol to extubate people quicker in the medical intensive care unit. I go through all this, I figure out what to do, and I just assume it's going to work in the SICU. Well, they're totally different. They have different goals. That doesn't work. Or we do something, and then we go, oh, that didn't work. Why didn't it work? Well, it seemed like a good idea at the time. We didn't think about it systematically. So I think we need to really step back and do this stuff with a lot of thought. So how are we trying to implement SMART? Well, the first thing we did is we went and talked and interviewed a lot of community providers. And we learned a few things. People were very worried about the cost of smart therapy. And this has informed some of our policy work that I'm not really going into a lot today, but we want to influence more payers, so more payers are covering smart therapy, like Missouri Medicaid. People told us they need tools because they're busy in primary care practice, right? It is hard to take your time and explain a whole new inhaler paradigm when you are talking about 5 other comorbidities and you are doing it in a small amount of time, particularly at an understaffed community health center. And people told us they need to learn. They need to learn how to prescribe smart therapy. So we took all these interviews and we began developing different tools and strategies to influence behavior. I'm just going to give you a couple examples, right? So this is one example. This is an asthma action plan that I think in reality a lot of people don't use, though they ought to. This is what it looks like, right? It's this big paper you fill out. You're going to take your fluticasone salmeterol, 151. You give them this paper. Probably there's not a color printer. At least we don't have a color printer in clinic. And so it's going to be black and white, right? And you go, good luck. And you document your note, I filled out an asthma plan. That's great, right? Great. I'd say there's probably a better way to do it. So we've been started creating all of these new tools, and we wanted a place to house them. And we came up with this website that we have this amazing team of graphic designers that have helped us put together. And we wanted to find an area that felt common to St. Louis, and we picked Forest Park and Art Hill, and we've recorded some videos there, and we've kind of made Forest Park our home. This is the QR code. It is up and live now. If anybody wants to go to the website, I'll also have that at the end. And this is some of our way of rethinking asthma action plans. So the one on the left is a one-pager, but I think what's even cooler is we have these little fold-out cards that go into people's wallet that explains how to use smart therapy, how to use your inhaler, what the contact numbers are if you need help. And we were very, very purposeful, and these are written at a third grade level. So I don't want to be the one to walk you through it. This is one of our community partners who, yes, we do have, she wants to be here. We have written media permission from her. And I'll see if this video works. And this is her, for less than a minute, walking people through their asthma action plan. How do I turn it?
Where's your inhaler?
Volume?
Right here, but I don't know how to use it. Really? I showed you this before. Here you go. That's yours. This is mine. What's this?
Well, you're gonna have to take my word on that. This is Mallory and her daughter walking people through the asthma action plan, flipping it through what the green zone means, what the yellow zone means,
The yellow, you're feeling pretty worse.
the red zone, what that means.
It's probably an emergency, and you need to call 911. This shows you how to use your inhaler, and you can refer.
And this is how to use your inhaler. And by the way, there's QR codes for more and more videos if you want to learn how to use your inhaler. This is your doctor's contact at the end.
Yes, you should.
That's it. So it's brief. So you can, if you're seeing somebody in clinic, you can say, okay, I'm prescribing this new inhaler paradigm, but here's this whole website that's designed for you on how to use it. Here's we're printing off these asthma plans, so you can give something to somebody right then and there. And I think that's quite a bit better than that black and white piece of paper that we just talked about. So we are rolling this out over the next few years. We call ourselves the CHESS study, and we are looking at this whole strategy that we're rolling out. If this is going to make providers more likely to prescribe smart therapy and ultimately, of course, improve asthma outcomes. And we have other aims, including assessing implementation outcomes. That map that I pulled up for you earlier, this is where the asthma morbidity in St. Louis was in blue, and the community health centers are red dots. Hence why we need to be partnering with our community health centers. This is the CEO of the Integrated Health Network, who's been very supportive of our work, and we will be excited over the coming years to tell you our results. This is our team of wonderful people working on this. I don't want to just leave that here, though. I don't want to just say, give you the evidence behind SMART and tell you we're going and doing work. I want you to leave here today feeling more comfortable prescribing smart therapy. So the next few minutes is designed for you. This is a practical guide for you to prescribe smart therapy. All of these sorts of things I'm walking you through are also on our website that I'll give you the QR code for at the end. So a practical guide to implementing smart therapy. Well, how does SMART work? SMART works by providing an inhaled corticosteroid when needed. It is not about just more inhaled corticosteroids, and it combats the SABA paradox that we talked about earlier. Does SMART work as quickly as a SABA like albuterol? Yes. SMART will work within minutes, just like albuterol, but the long-acting beta agonist in it has to be formoterol. And the reason being, something like salmeterol or vilanterol, the other long-acting beta agonists, do not have that quick onset. So they maybe won't work for 15 or 20 minutes, and then that person is wheezing and needs help right then and there. They're not going to get it. What dose of ICS formoterol should I use for smart therapy? Well, we have the benefit everybody in here is an adult provider, most likely, and so the dose is very simple. It's always the budesonide formoterol 160 dose, and when you're titrating it, you titrate it based on the number of puffs, not the dose of the inhaler. Do I ever prescribe SABA monotherapy? Well, Gina says you never ought to prescribe SABA monotherapy because they found benefits to budesonide formoterol in people that were having very infrequent asthma symptoms. And think practically about what you're telling people. If I prescribe somebody an albuterol therapy and then I need to step them up, I have to retrain them that their albuterol is not their reliever therapy. So if you just start right away at the budesonide formoterol, they're always going to view that inhaler as their rescue device that makes them feel better. Do I prescribe a reliever dose of 1 puff or 2 puffs? The correct answer is 1 puff of budesonide formoterol. The amount that it relaxes your airways, 1 puff of budesonide formoterol equals 2 puffs of albuterol. Do I prescribe SMART therapy in the hospital? This came up the other day, and the answer is no, right? So SMART therapy has not been studied in the hospital, and if you go trying to prescribe SMART therapy for your person with asthma in the hospital, I will tell you that budesonide formoterol, the main inhaler with SMART therapy, is not one of our formulary preferred ICS LABAs, and you'll have a whole problem with the pharmacist, and I would say that's appropriate because this hasn't been studied for the hospital setting. What amount of budesonide formoterol can somebody take with SMART? The correct answer is up to 12 puffs in a day, and that corresponds to 54 micrograms of formoterol. Can I prescribe SMART with other ICS LABA combos? The answer is no. It has to be formoterol, and you don't want to mix these things. You don't want to prescribe somebody something like fluticasone salmeterol maintenance therapy and budesonide formoterol reliever therapy because it hasn't been studied that way. Well, that person that can't get budesonide formoterol, is there anything else we could do? And I'd say yes, there is. And the two other possibilities that I can think of are budesonide albuterol and Pardix. Budesonide albuterol is a new inhaler that came on the market about a year ago. This just flips out from their albuterol. They take budesonide albuterol instead, and they're obviously getting exposed to the inhaled corticosteroids. Similarly, that reduces somebody's risk of exacerbating by between 20 and 30%. This inhaler is very expensive. It is not preferred by Mo HealthNet, so you're going to have those kinds of obstacles with it. The other one that has been studied, and this was a New England Journal of Medicine article from 2022, is called Pardix, Patient-Activated Reliever-Triggered Inhaled Corticosteroids. And that's where you tell somebody, every time you take your albuterol, take a separate inhaled corticosteroid. And I think that sounds good, sounds fine. Probably you're getting the same sort of thing. But the big problem I have with that is the practicality. Who puts 2 different inhalers in their pocket? I don't know. I'm skeptical of that. Is SMART safe? That's a yes. So this has been well studied. They had people repeatedly take budesonide formoterol doses or repeatedly take albuterol doses. They assessed things like their heart rate, their potassium levels, et cetera, et cetera. And the SABA group, the people that repeatedly took albuterol, had a greater drop in their potassium, and they had a higher heart rate than people that were repeatedly taking budesonide formoterol. And like I said, this has now been studied in 22,000 people. It's been reviewed by Cochrane and our guideline bodies, and there was no new safety concerns. What about people that have exercise-induced asthma? Get this one a lot, too. This is a study from Thorax in 2014 of 66 people. They all had exercise-induced asthma. It was a 6-week study. People either received placebo plus albuterol, received an ICS plus albuterol, or they received budesonide formoterol before exercise, and then they assessed their FEV1 drop with exercise. The group that dropped the most with exercise at the end of this study was the people that were taking their albuterol only before exercise and were not prescribed an inhaled corticosteroid. The people that were prescribed a budesonide formoterol before exercise had a smaller drop in their FEV1. So when I see people that come to me for exercise-induced asthma, I prescribe them budesonide formoterol. And I say, you're probably going to have a smaller drop in your FEV1 and you're going to do better in the soccer game. So when you're explaining these new inhaler paradigms, expect people to be confused. It's going to take time. Some of these people have been living using their albuterol therapy as a rescue therapy for 20, 30 years. We do, and this is not from me, this is from other people, that we have updated our asthma plans at Epic. I don't think we're the best at filling them out in most clinics, but they're there. When I have new residents or fellows in my clinic, they always go, well, where's the asthma plan? I go, well, go to your rarely used tab, and you might find it. You go to rarely used clinical toolkits, asthma action plans, and then you pull up the green, yellow, red stoplight, and the yellow zone is your reliever therapy, right? So the possibilities to pick for your reliever therapy are either albuterol, mometasone formoterol, or budesonide formoterol, the two combo inhalers that have the formoterol in them. They'll walk you through what the max number of doses are. There's also something for the red zone, and you can print it out right there for them. We are creating new tools, and I hope there are other sorts of things like the asthma plans that I showed you earlier that you can also give to people soon. So you can start prescribing guideline-recommended asthma therapy today. So I will end here with a thank you to the best team there is, and I will invite people to connect with us. This is two of our coordinators that are working on the study. This is our study-specific email, phone number. There's my office email and phone number. This is a QR code to our website. This is a figure that one of our graphic designers created for our website. I think we need to update it, maybe with the new tower. I don't. But thank you for everybody's time, and I'll put up the CME credit.
James, that was a great talk. Thank you so much. I didn't get all the questions wrong. I got a lot of them wrong, but thank you for educating us.
Yeah.
We have time for a few questions. Maybe I'll start. You clearly taught us not to use smart therapy while in patients, but what about when you're discharging patients? Can it be right as they go out the door, or is there some time waiting period?
No, right? I mean, it's a perfect opportunity. You have a captive audience. I think that would be a wonderful thing to study, is how do we implement smart therapy going out the door.
Can you talk about the balance between the implementation of the smart bundle, but also you kind of alluded to de-implementation?
Yeah.
Can you repeat the question?
Yeah. So I'll repeat what Mark asked that I think is obviously very, very, very correct. So we're really, he asked to do, there's two parts to this. We are implementing smart and we are de-implementing something else, and we're de-implementing albuterol. And this has been a lot of the resistance I've had, because people feel like you're taking something away from them. It's like, my albuterol has helped me for 20 years, and why are you taking that away? And so I think we need to think about it in that way. We need to talk with people. What do we tell them? And that's going to be part of the work that we're going to do together over the coming years. I think Enyo here, people that know Enyo, is a perfect example of somebody that's been thinking about de-implementing stuff, and that it is a little bit different of a mindset. Mo Health Nets has been really helpful on this because they are blocking people from getting too many albuterol refills. So if you go for more than your third albuterol refill in 6 months, they won't pay for it. And that is perhaps a hard way, but one way to de-implement stuff. You got to go back to your doctor and hear about budesonide formoterol. And I think also on things like our asthma plans, we have a line that budesonide formoterol works as well as your albuterol inhaler. So we have to really drive that point home.
James, I'm a CF doctor, as you know.
I do.
What happens with us is that patients are diagnosed in their childhood,
Yeah.
and probably same with asthma, and they carry their therapies forward. And unfortunately, when the research is done, it's done in adults first, and then it's done lower. Is the data as strong in pediatric patients? Is it not being implemented? To me, the easiest way for implementation is to start implementing in younger kids, and it's already carried forward, and the adult physicians can't make the mistake.
Yeah, so great. What Dr. Atkinson asked was implementing smart therapy in pediatrics. And so I'd separate pediatrics out into two groups. I'd say adolescents and then younger than adolescents. So our guidelines are very clear, and the data is very good, including the Sigma 1 and Sigma 2 trial down to 12 years old. So 12 plus, very clear, high quality data for smart therapy. There's 2 trials of smart therapy in 4 to 11-year-olds that had a similar sort of benefit, with the dose being lower, the budesonide formoterol 80 dose. And our pediatric colleagues are absolutely prescribing smart therapy. The data is not as good. I think, This is true in a lot of areas, that the data in pediatrics is not as good as in adults. But yes, I agree with you. It's a little different dose. They are doing it, but more work needs to be done to implement smart therapy in younger people. Our work is going to go down to 12 years old.
Great talk. Going back to what I learned in residency and everything was, of course, the control of asthma step down to the minimal therapy. Where does that sort of philosophy fit in the world of smart now? Like, if you've got somebody in smart therapy and you really have to people, is there still a role for stepping down?
Yep. So what Murali asked was about stepping down therapy and smart. Completely agree, and I'd also point out that we are not good enough at stepping down therapy. I think the norm for most people is that you step people up, and you're like, okay, now you're controlled, and you see them for years and years, and you never step them back down, and that's not correct. I would argue to you that smart therapy is perfect to step down, but you're doing it by the number of puffs, not by the dose. And so I do this all the time in clinic, and people love it. I try to give them control over their asthma. I say to them, okay, you're taking 2 puffs BID of budesonide formoterol, 1 puff as needed. As things get better, maybe it becomes winter and it's no longer the fall that's your bad time. As things get better, you can step down. You can even do it yourself. Dr. Beasley in New Zealand studying this for people to be able to do themselves, where they can go down to 1 puff BID or 1 puff a day. And then they can even go down further. They can just take 1 puff as needed. So the step up and step down, what's nice about it is it's always the same inhaler. And so you're not constantly flipping doses of inhaled corticosteroid or anything else. You're giving them the same inhaler, you're just titrating the number of puffs. So I would argue that it's easier to step up and step down.
On a practical note, can you talk about inpatient and outpatient at Barnard's Hospital and WashU? What is not happening, what is happening, what should happen in terms of inhaler education, inhaler use education?
Wow. So what Dr. Houston asked was perhaps opportunities for improvement in our inpatient and hospital to clinic sort of follow-up. And I think the point that Dr. Frazier made about trying to get people on smart therapy going out the door would be amazing. We have given this talk to residents multiple times. I think people are becoming more comfortable with smart therapy. I would love to see more people in pulmonary clinic. I would love I can think of quality improvements, opportunities for people to learn how to use inhalers, all of these sorts of things. Yeah. I don't know how well that's happening in the hospital. My guess would be not very well. We do have great respiratory therapists here. They're often very busy, but that would be a wonderful opportunity for them. I would argue if you're a resident and you are prescribing an inhaler for somebody, particularly a new one, you ought to sit down with them and be positive they know how to use their inhaler before you send them out. And do they have a spacer? You probably ought to be prescribing a spacer. This is low-hanging fruit for helping people. And these are the people that are at risk. This is somebody that was just hospitalized for asthma. So you know this person is the person that's going to be at risk of coming back.
James, thank you so much.